So hello everybody. I will tell you a little bit about my research. So I'm from the Radboud UMC. So I want to begin with a little bit of my background. So why are we doing this, and where am I from? So I'm actually working on stroke imaging a lot, and because of that, I want to give you a brief introduction into stroke. So let's have a look. Stroke is like the disturbance of blood flow leading to cell death, and you typically distinguish between two different types of stroke. You have like the hemorrhagic stroke, which is like a rupture of the blood vessels leading to bleedings, and the ischemic strokes, which are like a clot in the blood vessels, actually diminishing the brain tissue of blood. And those are two very important ones, but the latter one, especially the ischemic stroke, is very prevalent. And in both cases, it's really important to have an accurate and fast diagnosis in order to do fast treatment. And the treatment would be, in the case of the ischemic stroke, the removal or the flushing of the blood clot in order to clear the way and to prevent permanent damage to like your brain. So some facts. Actually, so like 12% of total deaths worldwide are because of stroke. The statistics are a bit outdated, I know that, but and also I saw in the first presentation that it's no longer the second leading cause, but apparently it was at the time. And the estimated cost is approximately 34 billion per year in like the United States. So it's a good reason if we could use imaging to improve this this field. So let's take a look at how the typical stroke workup is done. And this is the stroke workup within our hospital. It differs among the hospitals, but this is something of a vision that we have and pretty important. So the first type of scan that we typically is being taken when a patient comes in is the non-contrast CT scan, or the CT blanco. It's a 3D acquisition of the brain, and it's to rule out hemorrhagic stroke. So you want to see if there's a hyperdense spot on the images, and the bleedings really highlight very clearly. But if this is not the case, then still there could be suspicion of ischemia. Then you want to take an additional scan. They inject contrast liquids inside the arteries, and this will disperse through the brain. And while it disperses, actually there's a shot, another three-dimensional shot being taken. And also the vessels will really highlight here on this image. So you could identify which vessels are not really reached by this type of imaging. And finally, we have the CT perfusion imaging, which is done in our hospital. It's basically being done to detect which tissue is permanently damaged and which tissue is still solvable. The CT perfusion is a bit interesting since it's actually quite the same as the CT angiography, except now you take multiple acquisitions over time. So you get like a four-dimensional data per case. And we think that since this type of scan contains the most information, we actually have sufficient information to also like derive the other information from. And that could be useful. And why would it be useful? Because actually every one of those scans induces some radiation. So CT is known for its ionizing radiation, and you typically want to reduce that as well. It will both like reduces that, so the damage to the patient, but also like costs, because you can simplify the workup if you only have to do one scan, and that's also a good benefit. So we want to do only this, so only a CTP. But then, of course, there are some diagnostic information within the non-contrast CT and CTA which are not within the CT perfusion, and we want to get it somehow out, so we think we can reconstruct this somehow. Actually, the CTA reconstruction from the CT perfusion is rather easy because it's acquired in a similar fashion. So by simply like averaging over time, you already have a pretty good approximate. So we typically want to focus in this work only on the non-contrast CT. Yeah, so let's dive in. When you take a first glance at this problem and decompose it a bit, you get to see that a voxel value corresponds directly to a voxel value. Both are within the CT domain, so typically normalized through Hounsfield units. However, there is a difference in the kernels being used to get to this kind of images, and that's something that we typically see when doing that. But a typical good approximate of this would be that one voxel in the non-contrast C roughly corresponds to like an average over the time in the CTP signal minus the vessels. So that's actually already a pretty good estimate of what you want to achieve. However, as I mentioned, there are some differences. This is the ideal case, of course. But at least it gives us some baselines which we could use. So what we did here is, it's very simple. We just took the CTP signal for the first 3 images. These are like histograms, so they indicate like a voxel count in a certain domain of -100 to 300 on a log scale, just because there are many voxels in these type of images. So we just wanted to have a nice comparison and pull them a bit up, out of each other. And we did like an average over, an average. We just took the first time point. We took an average over the first 3 time points, and we took an average over all the time points. And for the non-contrasticity, as a reference, we plotted it. So we want those kind of distributions to kind of match. You can see that since it's a voxel count, actually we just included all the 90s. So these are a bit higher because they have higher counts typically than these. But also the distributions match way better for like the first 2 ones. And that's typically because the contrast material is not really perfused yet on the first few time points. It's by definition, this is a standardized protocol, so you can expect that the timing signal is not really, or the perfusion is not really gone that much into the thing. So what we can see here is that's different. So the vessel class actually has a closer towards the boundary of the one. So there's way more voxels actually being perfused there. It's also, you can see this in like a table. We can see that this is really high compared to all the others. So just averaging over all the time points is not going to be your solution to do this. And these reference centers are way better. But this gives at least an indication about the problem. And then here we can see we took the baselines, but the non-contrasticity values are a little below. So what we just did is take the difference and subtract it from the things to have a better estimate of the true value, because you could easily take this bias anyway, based on these statistics. So we have established our baselines. So then we collected like our data. 39 patients were selected from our hospital. We registered all the images, so we don't have to deal with motion. It's pretty convenient. Global rehearsable mapping of the Hounsfield units were done just to scale it a bit within for us, an acceptable range, but you could argue that isn't really necessary. Then we only are concerned with voxels within the brain mask. So we took like work within our group with just segments like a brain mask, and we tend to focus only on those voxels. And we split it, of course, our data set in some sets. Then the really important I want to stress is that it's high-dimensional data, so it's 4-dimensional. You have like a ton of voxels. It's pretty high resolution for standards for these kind of imaging. It's almost isotropic, which is quite a convenient feature. And we have like 19 time points. So if you do the calculation, you come approximately to 1.6 billion data points. That's quite a lot. And we thought, well, let's just take the most obvious approach, which is like going for a regression and within the brain mask. But we still need a model to actually do this. And we want a model actually to incorporate this spatial, temporal, 4-dimensional data. So we went back to class, recurrent nets. How do we deal with this temporal information? Well, this might be boring for a bit of you, but I want to go through this a bit fast to get an indication. A recurrent neural network takes some input and generates some output. It has some recurrent dependencies. If you unroll this is typically being done, then you can suddenly use backpropagation over this to get your gradients on top of this. It is a very general framework. The nice feature of this is, of course, that now you have like instead of a normal feed-forward network, you have like a one-to-one mapping, but you have now suddenly a broad variety of what you can do with like your input-to-output mappings, which is pretty convenient. But we tend to focus only on the many-to-one, so we just collapse all the data points into one, or we just keep we do a new mapping to a new set of data points. We keep all the data points there. Becomes more important later. But we have to look at like the internals of such a recurrent neural network, because that's really important. How do you implement those kind of things? starting at the simple recurrent neural networks back way the day. Basically, you just apply some kind of function to like your input and your hidden state, and maybe some function on top of this. And this is, of course, a great simplification. You could also like split your output from your hidden state, but essentially, this is the core. Here, they are the same. This was often found to be a bit too simple, so then the long short-term memory modules were introduced by like Hochreiter and Schmidhuber. And they essentially just deal with, this is a kind of formulation for it, but I won't go into detail too much about it. This is typically what you kind of see. This is the implementation that we also use. It's kind of preventing the vanishing gradient problem. At least long-term dependencies tend to vanish over time. So when you have like something at the first time point, something at the last time point, and when you are at the last time point, suddenly the things that you saw at the first time point do not have that much weight anymore. Well, they might be very important. And in our case, we know the first time points are actually very important. So we want to retain these, and we think that using a long short-term memory can actually help to add to this. Then, okay, so just shift this a bit in order to go into a bit of how we approach it further. So when you look at it, you typically actually just input like, well, it's not entirely true. I mean, you have batch sizes and you have channels, so actually it's three-dimensional, but for simplicity, we only focus on it's actually just a one-dimensional signal what you put in an LSTM. And then when you look at the computations, you suddenly realize that essentially you kind of do like a fully connected layer here. You apply like a fully connected layer, which is not really convenient when you want to put in like 3D volumes, which is something that we want to do. Then we can actually tackle both the spatial and the temporal data at once. So, well, it's not entirely true. I mean, you could like flatten, like you can reshape your thing, you can flatten it, and you can reshape it at the end. So then, but then you would just temporally only process your voxels individually. So you have no spatial relations. And we just want also to add the spatial relations because I think it's important, especially when dealing with noisy data like CT. You could really think that having a convolutional relationship is really important. So Xing Yan et al. Introduced like a convolutional LSTM, or at least it was already there. It's a pretty straightforward approach, but you just essentially just change your both the inputs and the hidden states. When you do a convolution over them, you can just kind of substitute this into your LSTM framework. And the convenient thing of this is that then you have actually new kernels which you can like play with. If you would keep the convolutions like just a one, of course you have like a convolution kernel typically, and if you keep it to one for both those things, then you actually will retain like LSTM. So it's a generalization in a sense. We like to split the kernel sizes for like the input and the hidden states because they both play a different role in this work. All right, so now we've covered the convolutional LSTMs. Now I would like to go on to briefly to bidirectional LSTMs. Actually, it's a very simple concept. You just take two of those things. You have one in one direction, but then you figure, well, you can also go the other direction and just combine those two, and then you get bidirectional LSTMs. It's nothing magical, but you just like duplicate the computations and you concatenate them in some sense. And this has been proven to actually generally like be better. So use more directions, generally better in a sense. Only a bit computationally more heavy. So then we come to our architecture. So how do we do all this, combine this? We actually put like these bidirectional 3D CLSTMs in a stack. So we layer multiple of them on top of each other. And we use like the many-to-many mapping. And finally, in the last layer, the many-to-one mapping to like get this information out. And now we have a framework which can analyze like 4-dimensional data in one go. That's essentially the idea. So we did some parameterization of this. So in order to experiment a little bit with this and get some feeling about what works, we just did a number of stacks. So you can stack arbitrary many on the top of this until you run out of memory, essentially. And you have variable fixed filter sizes and your kernels that I was talking about. You can also vary. We also added like an additional convolution here. but I'm actually not too happy with it. I think actually it can do without, but it is something that we added for these set of experiments. And yeah, it just has a number of stacks. We take only 3 times 3 convolutions, and we have a filter size for this. So going back to the method, we now have a model. That's good. And we want to train this somehow. So we thought about, yeah, we'll just take like an arbitrary number of iterations and randomly sample. But it's actually a bit tweaked, of course. We did some pre-experiments to see where it goes. But we fixed the amount of iterations for the experiments. And we optimized the mean square error. They're neatly like co-registered. So of course it has noise, but actually we think when you put sufficient data in and we have a lot of data points, we can actually just throw a kind of the kind of noise will be removed. Yeah, we use RMS proper default settings actually. Yeah, we need a big GPU for the data. Some implementation details. Moving on to the experiments, so we focused mainly on the number of stacks and the kernel sizes. We thought that were the most interesting ones. In these fields, we keep it relatively small and just improving kernel size. We just wanted to see what this does. And all the other parameters are varying a bit, but actually we think they don't matter that much. So we even think about ablating them at the end. But for now, we keep them around because we did those experiments in this way. We compared it with our baselines on default regression measures. We didn't know which one was the best, so we took them all. So we get these kind of results. Actually, yeah, significant differences between baselines and all experiments. It's pretty obvious. So you want to, the mean absolute error you want to minimize, and the mean squared error as well. Explained variance you want to maximize, and the R2 you want to maximize as well. And yeah, there are some outliers in the data apparently. But otherwise than that, in general, yeah, it's pretty good result. So we can also put this into a table, and because the differences between the experiments was not that clear from the previous plot, and then we go looking on and see that actually the second and the fourth experiment perform best. That's where with the most stacks and the bigger kernel sizes. So taking more temporal information over the time into consideration. Then for some qualitative results, what you see here is like the average over time, so T all. So this is actually our baseline. Here we see our reference, so this is like a non-contrast CT. And this is the reconstructed image. And you might think it does not look really like it, but it's actually, I think, a positive case here because it has learned to like filter out a lot of noise. And when you're interested in a signal of interest instead of fooling radiologists, that's actually a pretty good thing. So, and here we can see like the difference between noise. So we also know now that that's a bit of a problem with this, is that our quantitative measures are not really indicative of the clinical relevance results because we don't estimate that. And we probably would need to do some kind of study in order to evaluate that as well. And that we haven't done yet. But I think that's really interesting now. So in conclusion, yeah, we show that we have this hypothesis that stroke workup can be simplified by reconstructing non-contrast CT from CT perfusion images. And that is possible to derive high-quality three-dimensional reconstructions from 4D medical data. And that especially bidirectional stacked convolutional LSTMs are promising models for doing this. Yeah, I would like to add that we think, at least for this application, we are probably the first doing this. So, thank you.
Thank you very much for the interesting talk. Questions?
Thank you for the talk. I was wondering, you said that it's good that you filtered noise, but how do you know it was image noise and not a small perturbation in the anatomy, so a small anomaly, for example?
Yeah, well, actually, let me go into this. I think this explains it actually a bit. So we would have like your default neural network. You can decompose it in like your signal and like a noise perturbation. And since we know for sure that this holds, so we know that the error distribution of the input and the error distribution of the output are not equal. And of course, you need to kind of make an additional assumption that they're approximately zero-sum distributions. But then if you do that, actually you're approximating the signal and not the noise. So it's kind of like just a trick of like very nice simple math. And of course, this is a simplification. So you cannot never be entirely sure because there could be some noise which is overlapping between those things, but you would never know for that because that would just cancel out. So that you will not learn anything from that because it would be in both. Like if CT has some noise which is in both images, that you won't never learn, of course. Yeah. But this is a kind of reasoning for this.
Thank you.
Yeah.
Thank you for the interesting talk. I was wondering whether you think the learned model will have some intuition about the underlying physiological parameters you can measure with perfusion CT, such as zero blood flow or time to drain, and whether the kind of where it might happen to end up in the hidden states or somewhere, and whether it could be of clinical use.
In its current form, it's actually really only for kind of proving that we can do this reconstruction. But I think this technique could be applied to like other things. So you might think that there are a lot of those CT perfusion packages which actually also have like a regression model, also very noisy images. We could kind of use similar techniques to get something useful out of that. And also you like core penumbra segmentation, that kind of thing. You could really go this into an entirely different field. And yeah. This technique is, of course, pretty general in the basics, so you could apply it to any like spatiotemporal data. And in that sense, yeah, we think it has many uses, many new use cases. Yes.
Yeah, thank you for the talk. I was wondering whether you considered using 4D CNNs as well, and also whether you considered switching up the order of computation, so doing the spatial convolutions first, and then apply the convolutional LSTMs.
Yes, that's a pretty good question. Of course, that's very fair here, because you would like to have to compare it as well to such baselines, actually. I actually think there's something more inside this formulation that you would get out by doing first 3D convolutions and then things. And the thing is that you get this processing of spatial and temporal over time, which gets small motions, especially for motion, really small. For instance, let me take an example. These the CTP images here are not perfectly registered. I mean, you do a registration, but it's not perfectly registered. They have probably offset by some voxels. And by using this convolutional LSTMs, you actually also take those very small motions. It can a bit correct for that. And that's something that we found with experiments with taking just a kernel of 1 and a kernel of 3. So just by adding one voxel additional for the motion over time things, you can do this kind of stuff. So I think there's something in the combination of the two, but what is not in like the separate part.
Yeah, and 4D convolutions. What about that?
Sure. Yeah. Well, actually, for this type of data, 4D convolutions might still be very useful, but I think the formulation here, of course, for recurrency is you have a flexible amount of time points. So now we work with data only with 90 time points, but what if it would vary? And this is something that this model accounts for, and a normal 4D that would not do that. Of course, you can work around it. You could use like temporal convolution frameworks or something, but you would still have to do a reformulation of your things. One advantage of 4D convolutions would probably be that you could do it a little bit more memory efficient, I would guess. But yeah, you would have to test. And yeah, that's basically it.
Thank you.
So let's thank the speaker.
There's one more question.
Okay.
Hi, thank you very much. A very nice talk. So basically, you are doing regression of one volume based on 19 volumes, right?
Yes.
So from the temporal part of the workflow or the CT dose,
yes.
the X-ray dose, you are saving like 5% of radiation or the time. So
Yeah.
my question for you is, have you shown these images to doctors, and what do they think about it? Are they willing to use this technique instead of adding this 5%?
Yeah, it's a very fair question. I mean, yes, indeed. For CT perfusion, just takes way more radiation anyway, because you have way more things. So indeed, they lower the dose, but over time, the combined radiation is usually a bit more, of a lot more even. But we spoke to some radiologists. Actually, we have at our hospital the luxury of having radiologists next to us, and they actually think that that it could be very interesting. So just to have. And they think that they might be able to at least want to participate in studies looking if they can find the things that they find on a non-contrast CT on a reconstructed non-contrast CT. And if we could like prove that those are equivalent, at least we could reduce the step, which simplifies the workup. And in least it is a dose reduction, but I think that every dose reduction that you could get is essentially a win. So yeah, it's but yes, it's it's very important. Yeah.
Thank you.
So let's thank the speaker. Thank you very much.